This is part 2 in my weaning and extubating patient series, and in this video, we're going to be talking about spontaneous awakening trials. Like I said in my last video, weaning and extubating patients is more an art, in my opinion, than a science. Yes, we have all these fancy protocols, but this is where it gets a little bit tricky. Let's talk about things per the protocol first, and then I'm going to give you my little 2 cents here at the end. But what the spontaneous awakening trial does is it tells you to turn off your patient's sedation completely. So if they are on propofol and fentanyl, turn off the propofol completely. You usually can leave the pain medicine, and we're going to assess if the patient can go 4 or more hours without any of the following. So can your patient not be anxious, not be agitated, not be in pain, not breathe 35 times a minute or more for a sustained period of 5 minutes? Can they maintain their sats greater than 88%? Meaning they don't drop them less than 88% sustained for at least 5 minutes. Can they not have any acute cardiac arrhythmias or have 2 or more of the signs of respiratory distress, which is tachycardia, bradycardia, use of accessory muscles, abdominal paradox, or diaphoresis? If your patient doesn't have any of these boxes checked, you can move to the spontaneous breathing trial safety screen, which I'll cover in the next part. However, this is where it gets a little tricky. I'm telling you, from having 8 years of ICU experience, if you have a patient that's on propofol, fentanyl, whatever sedation that you're on, and you completely shut off that medication, they are probably going to have 1 or more of these boxes checked. You know why? Because the patient was going from being nice and sleepy and comfortable to boom, wakey, wakey, eggs and bakey. They've got a tube down their throat. Sometimes they're restrained and they are wigging out because they are scared. They're nervous. So this portion of a spontaneous awakening trial is where I say the art of waking patients up comes in. I personally prefer to wean my patient's sedation down a little bit slower, not saying you can't do it over like an hour or 2 period, but instead of just like completely shutting it off and being like, hey, I usually tend to wean it down a little bit, or I will usually ask my provider if I can have Precedex or something on standby, so that way I can start the patient on Precedex if they start to get anxious with their sedation turned down. In order to get a good spontaneous breathing trial, we need our patients to be able to be calm, follow commands, not be super anxious or agitated, and that can be really tricky to do when you just shut their sedation off completely. Not saying that there aren't cases where it's appropriate to just to completely shut it off. However, the majority of patients don't like it. But let's say you do turn your patient's sedation down a little bit and they are wigging out, their sats are low, they put themselves into AFib RVR, clearly not ready to extubate. You will restart their sedation at half the dose, titrate for pain and sedation, and then we'll return back to step 1.